Hello, my name is Gani Fananapazir. I'm a professor at UC Davis Medical Center, and we're going to be talking about imaging overview of the transplanted kidney. So just an outline for what we're going to be talking about. First, we're going to briefly talk about the vascular anatomy of kidney grafts. Then we'll talk about some of the major pathologies, which include vascular thrombosis, both arterial and venous thrombosis, transplant renal artery stenosis, arteriovenous fistulas, graft rejection, acute cortical necrosis, and acute tubular injury, and then finally round off with peritransplant collections. So let's start off with vascular anatomy. Most kidney grafts are transplanted into the right lower quadrant of the recipient, and the renal artery, as you can see here, is anastomosed into the external iliac artery. And so this is an end to side anastomosis. Now, sometimes the external iliac artery cannot be anastomosed, and then the internal iliac artery can be used. And this is actually as an end-to-end anastomosis with the renal artery and the internal iliac artery. And then another form of renal transplantation that can be done, not as commonly, is something called a pediatric en bloc kidney transplant, in which you have two baby renal donor grafts that are so small, the renal arteries are so small, you end up anastomosing the donor aorta to the usually the external iliac artery of the recipient. And usually these come with two, they come en bloc with both renal arteries, both kidneys from the recipient going into a single donor. So what does the vasculature of a kidney look like? Well, you have the main renal artery coming in. These divide into the segmental branches, which you can see here. And then you have the arteries that go in between the medullary portions. These are your interlobar arteries. And then finally, they arc around the medulla. These are your arcuates with your final terminal arteries, which are called your interlobular arteries. And it's your interlobular arteries that provide the perfusion to the cortex, which we'll see in subsequent slides why that's important to demonstrate. So now that we've gone over the vascular anatomy, let's look over vascular thrombosis. And we'll start with arterial thrombosis. Now, arterial thrombosis can be from an embolism, it can be from thrombosis or a dissection of the renal artery. And this is really not too much of a diagnostic dilemma. You just get absent perfusion to the renal graft. You can see here in this power Doppler image, there's no real perfusion that you can see. There's just some artifactual flow within the box that's being evaluated. And arterial thrombosis can affect portions of the kidney. So whatever renal artery, sometimes you have two renal arteries supplying it. Sometimes the thrombosis involves a branch of a renal artery. And so sometimes you can get normal perfusion to part of the kidney, as you can see here, and absent perfusion elsewhere. Now, this is an example here of the use of contrast-enhanced ultrasound, where you're using microbubbles to be able to look to see if there's perfusion in here. Here you can see the grayscale images of both pediatric en bloc kidney grafts. And then when we're providing contrast-enhanced ultrasound, there's no perfusion whatsoever within this. So this is arterial thrombosis. Now, this patient was taken back to the operating room and was underwent a thrombectomy, and there was perfusion was be able to be brought back to the kidney grafts. You can see a wedge-shaped area of infarct involving the superior pole of the more medial renal graft, and then you can see this collection around the medial graft. But this patient ended up recovering some vascular flow after an arterial thrombosis. So if these are caught super early on, there's the chance of being able to reperfuse the kidneys, but oftentimes these lead to complete graft failure. Now, venous thrombosis is a little bit more challenging because you don't have absent perfusion, but you have decreased perfusion. Arterial flow is able to get into the kidney graft, but the venous thrombosis is going to occlude flow from coming out, and so you'll get decreased perfusion and very high resistive indices, often demonstrating reversal of diastolic flow within the renal arteries. And there is overlapping features between acute cortical necrosis and acute tubular injury. These are usually distinguished by the lack of visualization of venous flow. So let's look at an example here. This is actually one of the pitfalls that we can see associated with renal vein thrombosis. This was actually labeled as the renal vein here, but you can see that when you play it on the cine clip, there's actually portions in which the vessel looks like it's heading towards the kidney. The kidney, in this case here, is on the left side of the image. So it looks like on the red, there's perfusion going towards, but most of it is the blue, which is going away. And so while was labeled as renal vein, this is actually the renal artery demonstrating reversal of flow, this intermittent, sometimes going towards, sometimes going away, which we can see on the spectral Doppler image. When we put spectral over this area, we can see sometimes it's going towards the kidney, but because of the high resistance from the venous thrombosis, we can see that there's this reversal of flow. The other thing to keep in mind is that when you have these areas of venous hypertension caused by the venous thrombosis, this can lead to rupture of vessels. And so it's fairly common in venous thrombosis to see these kind of peritransplant collections, which represent areas of hematomas. This is a case here where we're actually able to see the renal vein coming out. It's filled with slightly echogenic material. This ends up being a venous thrombosis that is able to be visualized on grayscale ultrasounds. This is an interesting case here of a patient who is presenting with concern for transplant renal artery stenosis. You can see the renal artery coming from the external iliac artery here is narrowed on this ferumoxytol enhanced MR image. But the interesting part of it is the vein here should drain directly into your iliac vein. So there should be a connection here, but there was no connection seen whatsoever between the renal vein and your external iliac vein, which is how the surgery had been performed. And instead, we can see this convoluted tubular shaped web of venous drainage from the kidney graft. And so this is a patient who had had chronic venous occlusion, but the patient had actually been able to create collateralization of vessels to other veins within the body. And here you can see on the angiogram here we're injecting the renal artery. We let it flow out. It goes into the renal vein. You can see how similar this image looks to the MR that was done with ferumoxytol. We can see this drainage to this web of venous collaterals. So, just because the vein is out doesn't mean it's always completely lost. If it's got slow occlusion or gradual occlusion, collateral vessels can form. Now let's talk about transplant renal artery stenosis. So transplant renal artery stenosis involves the inflow from the arterial side to the kidney graft being narrowed. And this can occur in a number of different locations. One of them could be pre-anastomotic, involving your iliac artery or even your aorta. Anastomotic or ostial, keeping in mind that most kidney grafts, when they are anastomosed on this end to side anastomosis here, they will come from deceased donors, oftentimes with a patch of donor aorta that's sewed onto the external iliac artery, and this is referred to as a Carrel patch. So most of them come with a Carrel patch. So what is actually seen as anastomotic doesn't really apply in most cases of deceased renal donors. And we're really talking about ostial lesions or stenoses that occur at this area. You can also get transplant renal artery stenosis involving the main renal artery or even the segmental renal arteries. So there's all different kinds of locations for arterial stenosis to occur. So here's an example here of a proximal renal artery stenosis. You can see the image, and then it goes back to your angiographic view. We can see this is a proximal stenosis. If this patient has not had a Carrel patch, this could be called an anastomotic. But if a patient has had a Carrel patch, this would be referred to as an ostial stenosis. Here's one here where you can see the narrowing is in the mid-renal artery, and then we have the angiogram to show that that stenosis was real. It involved the main renal artery right there. And then this is an example here of a kind of diffuse renal artery stenosis, which is involving almost the entire renal artery with a little bit of sparing in the mid-renal artery. And so when we looked at UC Davis at, what are the distributions of transplant renal artery stenosis that we see, we can see the most common is actually involving the main renal artery, the second most common being ostial stenosis, and the third most common being anastomotic stenosis. So, bottom line is, calling things anastomotic is probably unfair. Sometimes uh, transplant surgeons can be feel some blame associated with them being called anastomotic. So, given that most of them come with a Corel patch, that's probably an unfair statement to refer to these as anastomotic in all cases. So what do we see on ultrasound? Well, we see a few things. Here's an example here of our iliac artery, and you can see the renal artery coming off. We have very high velocities here. You can see the aliasing that's going on there. But the other thing that we see is that there's vibration that's caused by the turbulence into the soft tissues, and that's picked up in Doppler. You can see this kind of bloom of what looks like Doppler signal. And all that is the shaking of the adjacent tissues. So we get soft tissue vibration. We can actually see the soft tissue vibration on spectral Doppler. Here you can see, during every systolic peak, there's this kind of low amplitude uh, waveform that you can see there. This is actually just the soft tissues vibrating. This is your actual um, waveform here for your renal artery. You can see high velocities. We can see spectral narrowing. We can see all this clear space under the spectral envelope. And then more distally, what we end up seeing is spectral broadening because things become choppy downstream from the stenosis. So you can see this is all filled in. This would be spectral broadening. And then when you get more distal, you can actually see a delayed upstroke, which is usually diagnosed as more than zero point 0.1 seconds to reach systolic peak. So, how do we deal with all these different ways of looking at stenosis and characterizing them by ultrasound? Well, there's one study that we looked at where we found that there were only three major risk factors that are really important for assessing transplant renal artery stenosis. One of those is a velocity greater than 300 centimeters per second. The second is turbulent waveform in the renal artery, so seeing that spectral broadening within the renal artery. And the third is a parvus tardus waveform, the delayed upstroke of greater than zero point 0.1 seconds. And so what we ended up finding was that the risk goes up. The risk for transplant renal artery stenosis goes up depending on the number of risk factors that you have. That if you have zero risk factors, you don't have any of those three qualities, then you have a low risk of having a transplant renal artery stenosis. If you have all three of them present, you have a very high risk. But interestingly enough, if only one or two of those are present, you still have a fairly significant chance of having a stenosis. So even, for example, if you don't have a velocity, if the velocity is less than 300 centimeters per second, but you see turbulence of flow within the renal artery and or you see a delayed upstroke within the intraparenchymal renal artery, then that may warrant further evaluation with some other modality. So this is kind of how we report things at UC Davis is that we look at those three risk factors, we say whether they're present or not, and then we'll make our recommendations based off of what we're seeing. And, low risk usually doesn't require anything further. We've kind of ruled out transplant renal artery stenosis at that point. But when you have intermediate risk or even high, very high risk, what we do at UC Davis is we do an MR with ferumoxytol, which is an off-label contrast agent, which is um, an alternative to giving patients gadolinium who oftentimes have renal dysfunction as well. So that's what we do at UC Davis to be able to further evaluate them before undergoing an invasive angiography. So, just a few pearls. One is look beyond the anastomosis. Most cases are actually not anastomotic and involve the main renal artery. To look beyond the velocity alone, the importance of spectral broadening, the importance of a delayed upstroke, those things need to be looked at. And then finally, to consider the use of non-invasive modalities to assess for stenosis in those cases where it's intermediate or even high and very high risk for transplant renal artery stenosis. And I'll just show a few example cases. Now, you can do an unenhanced MRA. Those are challenging in renal and transplanted renal arteries because they tend to curve and bend, and unenhanced MRAs are not as good at depicting those, as you can see here. Ferromoxidil enhanced MRA, here you can see this narrowing right here at the origin of the renal artery, which corresponds very nicely to the actual digital subtraction angiography that was performed. Other possibilities is to use contrast enhanced CT as well in these patients. Here's another example here of a ferromoxidil enhanced MRA that was done. We can see here our transplant renal artery stenosis proximally within the renal artery, but we can also see that there's a dissection here, which was very useful for the interventional radiologists to be aware of because they knew to come through the ipsilateral femoral artery when they were trying to access this right external iliac artery to avoid that dissection. And then finally, we've just found it useful to do ferromoxidil enhanced MRA because you can actually figure out the table positioning that can best image your transplant renal artery stenosis. So we actually can provide a roadmap for the interventional radiologist to be able to best visualize the stenosis that may be present. Okay, moving on to arterial venous fistulas. Now, arterial venous fistulas are abnormal connections between the artery and vein. They oftentimes occur during biopsies. So here's a needle going from the artery to vein. It creates a channel between the artery and vein and is a low resistance. It's avoiding the higher resistance capillary beds distally. And so with this abnormal collection or connection, creates a shunting of blood to preferentially go down into the vein. And so there's going to be decreased perfusion distal to this arterial venous fistula. So you can have areas of decreased flow within the more distal portions to the arterial venous fistula. So what do you end up having? Well, one of the things you have is tissue vibration. Remember that tissue vibration can be picked up in Doppler, and so this is actually a very useful technique to be able to screen for arterial venous fistulas, to look for this area, and sure enough, we can see there's something going on right here. And when you end up putting a spectral Doppler over there, you can see this high velocity, low resistance waveform pattern consistent with an arterial venous fistula. Here's an example here of a patient who had two graft renal arteries. One of them had, I think it was the inferior pole, had a arterial venous fistula, and you can see that the supplying artery to that had a low resistive index. In this case here is 0.47. And the unaffected side had a much higher resistive index at 0.88. And so you can see what the perfusion difference is between areas that are affected by an arterial venous fistula and those that are not. And here's just another example here. Here is a biopsy that was performed, an arterial venous fistula was created, and this kind of nicely shows on this B-flow image, which is a non-Doppler grayscale way of being able to depict flow. Here you can see the arterial venous fistula. Here's the cortex of the kidney, and you can see there's this cortical perfusion defect here created from shunting of the blood away from this particular area and preferentially just going into the renal vein. So arterial venous fistulas can create areas of hypoperfusion within the graft itself. We're going to next talk about graft rejection. Now, graft rejection has a number of classic signs that have been talked about in radiology literature. It talks about high resistive indices, increased echogenicity, corticomedullary differentiation. There's a number of different things that are classically discussed with graft rejection. However, recently we looked at this and we found that none of those signs really held up in being able to differentiate rejection from other causes of renal dysfunction. And in fact, the average rejection resistive index was within the normal range. So we didn't find that to be particularly useful. The perfusion looked pretty similar. The graft size looked pretty similar. But the one thing that we did notice that was quite different is there's urothelial thickening. And you can see this urothelium here is markedly thickened. We found this to be a very sensitive finding for rejection, but not a very specific one. There are other entities that can cause urothelial thickening. But if you see that, it's one of those things that's useful to raise the question of whether this patient has rejection. And sometimes this urothelial thickening can be mistaken as hydronephrosis, but here you can actually see that there's thickening of the urothelium here. Here's another case here on a cine clip where you can see the ureter coming out right here is actually markedly thickened. So when you see markedly thickened ureter, think to raise the question of whether the patient has rejection. Now, acute cortical necrosis and acute tubular injury really show why graft perfusion is important. And we saw that graft perfusion can be decreased in cases of renal vein thrombosis. It will be absent in patients who have renal arterial thrombosis. But graft perfusion for acute tubular injury and for acute cortical necrosis is really important to have good assessment. And so here you can see power Doppler, we have color Doppler on the left. And then my favorite is actually B-flow imaging, which is, again, a non-Doppler way of assessing for vascular perfusion. And one of the reasons I like B-flow is one, you can see the vessels much clearer. But two, there's very little that the sonographer can do to be able to exaggerate flow. Really, all you can do is change the gain on the B-flow image. You can't do all of the other things that you could do with Doppler to be able to manipulate whether or not there's perfusion within the renal graft. The other option that we have for looking for graft perfusion is contrast enhanced ultrasound. And I find this particularly useful in those cases where there's decreased perfusion and you don't entirely know whether it's acute tubular injury that's causing that or acute cortical necrosis. Contrast enhanced ultrasound will do a good job of being able to see whether there is flow to the cortex. If there is flow, then it's more likely to be acute tubular injury. And if you don't see flow to the cortex, then that's going to be acute cortical necrosis. And so one of the things that we're going to talk about is this perfusion, hypoperfusion, reperfusion injury that you can see with kidney grafts that normally they have the artery supplying blood, the vein draining blood. And so here you can see within the vasculature, you can see the endothelium, the cells there. You can see the tubular cells here as well. And then when you take a kidney out from the donor, there's a time where there's some ischemic time, where there's no perfusion getting to everything. And so those cells are hypoperfused as well. And then when you reperfuse the kidney, what ends up happening is now all these inflammatory cytokines start creating inflammation and swelling within the vessels that are lining the endothelium, as well as within the tubules. And so you can get decreased perfusion or decreased blood flow to the kidney graft, and you can get decreased urine output from all of the swelling from the cells surrounding the tubules. And this can sometimes lead to necrosis if there's not enough blood flow that's getting through the kidney because of the reperfusion injury. And so this is kind of the pathogenesis behind acute tubular injury and potentially acute cortical necrosis if things are pretty significantly swollen that it ends up causing no flow to the cortex of the kidney. So here's an example here of acute tubular necrosis. Here we can see that there's low perfusion state to the kidney. It's not nicely perfused, but we can clearly see this renal vein that's coming out from there. What we're going to see on the arterial side is high resistance waveforms. Here you can actually see reversal of flow within here. So that's very classic for acute tubular necrosis. And then here we just put spectral waveform on the vein just to make sure that this is venous flow, and sure enough, it is venous flow. So acute tubular necrosis is very common immediately post-op. It's diagnosed on biopsy and is oftentimes self-limiting. Acute cortical necrosis, on the other hand, is the much more severe form where you end up getting absent flow in the renal cortex. And so here was a challenging case. This one here, you can see this perfusion getting to the kidney, but maybe not out to the cortex. On the B flow mode, you can see central flow quite clearly, but there's no flow out in the cortex. And even when you do sample some of the areas of arterial flow that are seen, the resistive index is normal. And that can be seen with acute cortical necrosis because blood is shunted away from the cortex. The resistive indices can actually be fairly normal. Here's an example, another one here of acute cortical necrosis. When the cortex becomes necrotic, it can become much more hypoechoic, and you can get this hypoechoic rim appearance to the kidney graft. Here we can see on our Doppler image that there's decreased perfusion. And then we were trying to figure out, okay, is this acute tubular injury or acute cortical necrosis? We ended up giving contrast, and you can see that there are areas that just have no perfusion within the cortex as well that ends up diagnosing this as acute cortical necrosis. Finally, we're going to look at peritransplant collections. Peritransplant collections can be divided into time points. So one of the early collections, those occur within the first month. Those are going to be your hematoma, your urinoma, and your seroma. And then you can get those with late presentations. Those are going to be mostly lymphoceles. And then you can get iatrogenic injury, which usually leads to hematomas, but could potentially lead to a urinoma as well. And then all of these collections can become infected, so they can end up becoming abscesses, any one of these collections. But I just wanted to focus on hematomas because I think this is important. The location of the hematoma kind of gives some ideas to the prognosis of that particular hematoma. We have incisional hematomas, which are the least scary. We have lateral hematomas, which are a little bit more scary. Subcapsular hematomas, which can have significant uh, concerns for the health of the kidney graft. And then the medial hematomas, which can be life-threatening. And so we're going to go through some example cases of this. So here's an image of a body. You've got a kidney graft in here. You've got your artery, your vein, and this is an incisional hematoma. It's just right underneath the skin. Not much can happen with these. If they're large enough, they can potentially get infected, but these are usually self-limiting. Now, lateral hematomas are usually from some kind of venous ooze, and these can actually can become quite large and can cause some mass effect on the kidney graft. But again, these are oftentimes self-limiting. Now, the subcapsular hematomas are hematomas that are contained within the capsule, and because of the pressures that they can create, uh, they can really have quite an impact on the kidney graft. Here you can see the scalloped appearance of the edge of the kidney caused by the pressure from this subcapsular hematoma. And so, because of the increased pressure and increased resistance, it's understandable that we'll see low perfusion and also reversal of flow within the renal artery that's supplying that. And oftentimes, these subcapsular hematomas can be very difficult to see by ultrasound. Postoperative patients can be difficult to evaluate their kidney graft, and this is an example of one of them where here's your renal graft here. We can see there's not a lot of perfusion going in there. When we are able to look at the arterial waveform, we see that there's a reversal of flow within the arterial waveform. A CT was done, and when we windowed it correctly, we were able to see that there, yes, indeed, there was a subcapsular hematoma that was going on. Now, the ones that are really concerning are these medial hematomas. And here you can kind of see the medial hematoma here. Um, medial to the kidney graft. This was placed in the left lower quadrant. So this is the medial collection here. And the reason you worry about medial collections is that these can be due to injuries to the renal artery or the anastomotic region and maybe have an anastomotic breakdown. And sure enough, that's what was going on in this patient here. Here's the renal graft, here's the collection, and we can see this hypodense area within this more dense collection. This ended up being a pseudoaneurysm resulting from rupture of the anastomosis. So it's one of those things that when you see a medial collection, have a lot of respect for it and consider asking for contrast in these particular patients just to make that diagnosis. Here's an example here of coronal images of CT. We have the kidney graft on both sides, and then we have this medial collection here. And then when we gave contrast, you can see these areas of contained vascular injury. This was another anastomotic breakdown from renal transplantation. And so these ones are life-threatening and need to be acted upon. So in conclusion, venous thrombosis, you have your low perfusion, reversal of flow. The venous outflow is absent. For acute tubular injury, is low perfusion, reversal of flow with the venous outflow being present. When we're thinking about acute cortical necrosis, we think about absent perfusion, potentially normal flow in when one is assessing the arterial resistance, and venous outflow is oftentimes present. When we're thinking about arterial venous fistulas, look for tissue vibration on the Doppler. When we're looking for transplant renal artery stenosis, remember that we are looking for velocity greater than 300 centimeters per second, spectral broadening, and delayed upstroke. And, any one of those things should elicit potential further evaluation, perhaps with an MRI. When we're talking about rejection, look for urothelial thickening. That's the most sensitive sign for graft rejection. And then finally, when we're talking about peritransplant collections, beware of those medial collections.